Conference room number accepted. If you are the organizer, press the star key now. Otherwise, please hold. This line is now muted. This conference will now be recorded. For a menu of available commands, press star 1. There are 14 participants in the conference.
In the medical field. David Mance has over 30 years experience in healthcare in a broad range of clinical and leadership positions. Since 2012, David has been the CEO for Chico Memorial Medical Center in Lake Village, Arkansas, which is a 25-bed CAH that employs approximately 145 staff and 3 physicians and hosts multiple external outreach specialty clinics and services. He is responsible for leadership and oversight of all areas of operations, financial management, and community relations. He previously worked as the executive director of operations at Salina Regional Health Center, which is a 250-bed acute care hospital in Salina, where he was responsible for multiple departments and programs to include patient satisfaction and telehealth. Eric Schell is the director and principal consultant at Stroudwater Associates in Portland, Maine, and has over 25 years experience in healthcare financial management. Eric assists rural hospitals, health clinics, and physician group practices with improving financial and operational performance and developing strategic and operational plans. Eric has been instrumental in assisting rural hospitals in developing strategies for transitioning from fee-for-service to value-based systems. He has worked with the Department of Housing and Urban Development to implement a financing vehicle that enables rural hospitals access to capital markets and assisted in the development of a national program for rural hospital performance improvement and measurement. Terry Hill, Executive Director of Rural Health Innovations, will facilitate today's discussion. And now I'll turn it over to Terry and our hospital leaders.
Thank you very much, Nicole, and welcome everyone to the call. This is part of the Small Rural Hospital Transition Project. And in that regard, Eric Schell and I, one of our speakers, go back, it's been almost 14, 15 years when we worked with a small hospital in Mississippi. And since that time, for the last 15 years or so, we have been supporting rural hospitals across the country in terms of performance improvement, including financial improvement, operational improvement, et cetera. In our current iteration of this project, which is funded by the Federal Office of Rural Health Policy, we've added an additional dimension. So beyond just the performance itself, we're now looking at how our resources and how our program can help rural hospitals make the transition to the new payment system, the new value-based payments and the population health payments that are starting to kick in now, but we expect to really become a greater part of our payment as we move forward. Everything that we can see, I can just tell you right up front, is that this is not a temporary transition or one that's going to be somehow hijacked by the political processes, et cetera. The transition is well underway, and one of the things that we have seen over the last year is a tremendous movement on the part of rural hospitals into accountable care organizations, into primary care medical homes, to Medicaid demonstration projects, et cetera. And while our critical access hospitals continue to have cost-based reimbursement, it's becoming increasingly clear that small rural hospitals will have to find their role in the new healthcare delivery system. And in that regard, we have been working with individual hospitals, 2 of whom are represented on this call. A primary consulting group that we use in this program is the Stroudwater Group, and Eric Schell, their director, and somebody who does the vast majority of our financial and operational assessments, is on the call today. So to me, this is an incredibly important topic. Like Eric, I travel around the country talking to hospital leaders, and this is getting to the top of their priority list. And we don't think there's any single way to transition to that future, but we think that there are tools, there are resources, there are strategies that we're trying to outline, resources we're making available on our website, and webinars and performance management group calls like these, so that our hospital leaders, over 2,000 rural hospitals across the United States will have access to these resources, tools, and either live webinars and calls, or these calls are also and webinars are also available on our website as well. So with that, the other person I want to acknowledge is Janine Myers, our project officer for the Federal Office of Rural Health Policy, and again our RHI and center staff here who do really a very great job. I'm going to move now into kind of the questions for our panel. And again, as Nicole noted, we have two stellar hospital administrators here, and Eric Schell, who I know has worked with hundreds of hospitals just since the time that I've known him. So I'm going to start. Let's go with Melissa. The first question I have for you is, what was the catalyst for your hospital engaging in this financial and operational assessment through our small rural hospital transition project? Melissa?
Well, I think we really just knew that we were operating quite well, but there was always room for improvement, and so we wanted to take the opportunity to work with some consultants to see what other things were available to take our operations to that next level. And then finance is something that keeps me up at night, knowing that our critical access reimbursement is always something that's under question and under fire these days, and just making sure that we were setting ourselves up to be successful long term.
So your hospital wasn't in crisis. There were no kind of major crisis areas at this particular point. It was kind of thinking ahead to figure out how, not just how can we be successful today, but into the future as well. Correct.
We provide a major economic boom for our community, and just making sure that we are able to continue providing that economic stability for our community long term, and by making ourselves as financially viable as we could.
Okay. And also the same question to you, David. What was the kind of the incentive to apply to participate in the program? David, you'll need to hit star 2 to get it.
Yeah, okay, I think I've got it now. Actually, a little similar to Melissa's situation. We had already begun realizing that we need to transition, and our team had already started voluntarily participating in the HCAPS program and really paying attention to patient satisfaction, as well as we had implemented a really strong performance improvement program, and we have some people that are really dedicated to running that side of what we're doing. So we just needed more, and particularly in the revenue cycle side, we had some weaknesses, and really knew that we just needed to increase our vision and focus on some priority areas. As you know, small hospitals don't have an overload of resources to deal with, so we had to be a little more pointed with our energies.
Yeah. One of the things that I want to point out, having worked at lots of hospital administrators, is that it's not inconsequential that it's not necessarily easy to bring in consulting teams to the outside, from the outside. They, as David said, they have a wealth of resources. They can supplement your staff, but it takes a lot of time and energy sometimes it's difficult to look in the mirror and say, gee, we're not as good as I was hoping we'd be, et cetera. So those of you that do participate in this program, it's really clear to me that it takes a commitment of time, energy. We don't charge for these services because they're funded by the federal government, but I think we're all clear that when you invite us into your hospital, that's really something that you have to put a lot of time and energy, and there's disruption to some degree as well. But we try to make sure that the outcomes more than justify the intervention of time and the cost of time and resources here. Talk a little bit, David, more about what happened in the consultation in terms of talk about the team that came in, how long they were there. If you would, just kind of describe the process that was used.
Absolutely. And I will echo a little bit about what you're saying. It is a commitment, and the team was very clear that they didn't want us to just take advantage of the week they were here and the visits they made here and the presentations, but you really have to invest going forward with actions and seeing those things to real fruition to make it worthwhile. Eric was a delight to work with, and we had a couple of folks that helped out. In particular, one of the biggest things, I think, was the education the team brought. A lot of times it's hard to have the impact you want when you see folks every day or see the board every month, and you can bring someone in with that experience and that delivery that the team brought and make a big impact on your board to really create a sense of urgency. And our administrative team had been going down the road of preparing for the transition and looking at value-based purchasing and educating the board on what that meant, particularly for a PPS hospital, and how do we prepare for that? How do we really kind of look into the future and create that culture before reality hits here, and then so we don't start preparing at that point. But they had a huge impact on our board, and I will say also on our providers. They did presentations for the board in particular, but we also had a dinner meeting, and there was an excellent presentation regarding a multitude of things related, basically working toward population health management, but looking at value-based purchasing, looking at bundled payments, looking at ACOs, and just really bringing that information and knowledge to a small area that, the board is voluntary. Their scopes are banking, farming, school, education, different things. So they don't have time to research and study. So that intense and well-produced training episodes, I think that meant a huge amount to our hospital.
I think you just mentioned two absolutely important groups here that are sometimes overlooked until too far down in our transition process, and that is the board of directors, as you said before, and the second group that you talked about is your medical staff as well. My observation is that hospital leaders, rural and urban, are becoming clearer. They have more education available to them, et cetera, that is targeted directly at them. What we're finding is that we're not finding the similar education to rural physicians, and that this is becoming a huge, I think it's a huge problem. In some states, the hospitals have actually identified board education as close to the top of their priority list as well. So for quite some time, we have included these educational pieces in, and again, the hospitals report, as you are, that it kind of opens that door, and you know how it is, David, with if you're the local guy, we have the same issue here where I'm from. If you're local, it's like you might be saying this for some time, but to have somebody come in from the outside, yeah, it really helps. Melissa, you have somewhat of a different circumstance in that my understanding is you're participating in an accountable care organization right now. So can you tell me a little bit about, how that might have kind of influenced your decision to come in? Talk a little bit about the process, in your hospital and kind of how it evolved.
Certainly. I think what this project did was really focus us in on asking some very pointed questions about the ACO that we were participating in, and I think it highlighted to ourselves and to our board that we needed some clear-cut answers on how that ACO was going to work for us, as well as some of the benefits that the ACO provided to us. And so I think it really focused our board on asking some of those tough questions that maybe got overlooked initially when we went on board with them.
Melissa, did you believe that? I mean, is your board of directors? Would you think they were knowledgeable about what an accountable care organization was? I'm wondering about how thoroughly they understand the changing financial incentives, just the whole healthcare landscape in general. Is that something that you've been able to accomplish, or is it a work in progress, or where is your board on that?
I certainly think that they felt the need to get some more education. I feel like we are still in a learning phase of that discussion, but it certainly encouraged them to be a lot more aggressive, and I would say that our board has really come into its own. Again, it's an elected board with 5 members. All of them have other commitments in the community, and they're not able to just look at their board duties as a full-time position by any means. And so trying to provide some of that education, but really seeing their outlook at the board level become more strategic and really thoughtful and futuristic, rather than focusing primarily on financials and things that needed kind of rubber stamp approval at their board meetings. That they took that ACO discussion and applied it to all of their board agenda items and made them all more strategic in that nature.
And David mentioned that in his hospital, it was a good education, and it was very productive from a medical staff standpoint. Could you talk about how your medical staff has been involved, and kind of just your perspective of how they're evolving kind of into the new payment system?
Absolutely. Again, I think we still have some room for education, but I know we had one provider attend our board meeting that night and really felt that he was engaged in that conversation and truly took to heart kind of some of that understanding that we're really at a tipping point where the fee-for-service is going to be going away, and we need to figure out how to bridge that gap to population health. And I think then he's able to take that back to his peers and have some discussions around that situation and continue to evolve that discussion as we move forward. So it was a big step for that group, and we continue to try to get them engaged and continue that discussion as we move forward. So they're starting to hear a lot of those things. They're starting, particularly with the ACO, starting to see some of those quality measures and how we raise the bar as we prepare ourselves to make that transition as well.
So I'm going to, call on Eric Schell to talk a bit about, kind of your experience going to those hospitals, also your perspective with the boards and particularly the physicians, which I know you think is extremely important. Eric?
Talking to me. So first of all, I'm glad that we're spending some time on this here on this call, and that's the board and med staff education. About 2 years ago in our firm, when it became pretty clear that the market was moving and probably not going to come back to this world of fee-for-service, that we were moving as an industry towards a new payment model, the chairman of our company made a statement. He said, doing the same old better is not going to be sufficient going forward, that we are going to have to rethink strategy. And hospitals are going to have to rethink kind of their overall strategy as it relates to the delivery system, the sick care model that we're in today, around creating a health system, creating that population piece, and then transitioning payment. And so what was left at the table here was the key to changing strategy was engaging board and med staff around kind of this new way of thinking. And so this idea of doing yesterday, a little bit more efficient or a little bit better, or we can do this, that I don't think that exists any longer. And so, again, I think it's really important for hospitals that they do engage their board and they do engage their med staff on these issues. And kind of one thing that you guys is available it's on our website, and I believe Terry, you have it on your website too, is the presentation, an updated presentation of what I gave to both David and Melissa's hospital is now on the website. It was filmed about 2 months ago at the Iowa Hospital Association's annual Critical Access Hospital Conference, and they did a really nice job professionally filming it. And that's a resource that's available right now out on the web. And I've had hospitals sit down and do lunch and learns, dinner and learns with their board just to get a common language in place related to what this new world's going to be looking like. So, Terry, I'm not sure I've asked the whole part of your question, but I think I got a piece of it out there.
Yeah, and one thing I want you to expound on just a little bit more is the vital importance of getting the physicians engaged, because they're at the heart of the new payment system. I don't think we can stress that too much, Eric, so I just wanted to make sure that you made that comment as well.
Yeah, I think this comes back to Terry's had to put privilege or pain of hearing my presentation the last couple times now, and one of the important pieces of the new world is that in the future, revenue, dollars are going to be attached to patients, and in most cases, patients are going to be attached to primary care physicians, and the strength of the value, the future economic value of a rural hospital is going to be directly tied to the strength of the relationship they have with their primary care physicians in their community. We can have employed doctors completely unaligned. We can have independent doctors completely aligned. The key is within our rural communities is to recognize that the revenue in the future is going to be tied to that primary care through the patient, and our relationship and the strength of our alignment with that primary care is really what it's all going to be about. I know David took that to heart, and I know in Lake Village, Arkansas, and still working on that strategy. And Melissa's she was fortunate enough to have already employed most of the primary care physicians in her service area. So I think it's really important that the physicians understand that, and the hospital understands that, and boards, so that there is this ultimately fundamental coming together within our rural areas. I've said in this presentation that's filmed here in Iowa that I think we're going to lose 10% of rural hospitals. That don't have a strong alignment. Others will come in, whether they be Wall Street-backed companies or they'll be the big hospitals from the big cities, will come in and essentially acquire the primary care practices from the hospitals. And frankly, that's the revenue source. The hospitals in the new world are bricks and mortar, and they're an expense center. And what we've got to do is be really careful that we're not one of the 10% that doesn't have that fundamentally strong alignment strategy with their primary care doctors.
Yeah, absolutely. And there are increasing number of programs coming out of CMS and out of the federal government that are primary care physician based. And in that regard, it's a great strength for rural hospitals. That's wonderful from that standpoint. On the other hand, the necessity of maintaining that strong alliance, partnership, et cetera, with our medical staff becomes even more essential because they're of high value in the new system, while in contrast in the old system they were much more limited value, just in terms of dollars and cents and financial outcomes. Mm-hmm. I'm going to ask David a bit, talk a bit about what came out of the visit. You've talked, the larger concepts, but more specifically, what kind of goals did you have after the, particularly the first visit and even the second visit in that regard? What were you trying to do from a financial standpoint? Were there any specific issues or problems that you put in some objectives to fix, et cetera? Tell me a little bit more about the recommendations coming out of the consultation.
Yeah, and there were really several areas. Of course, now that the consulting team looked at every area in the hospital, spent a lot of time with departmental leaders. It wasn't just CEO level. It was in the weeds, and lots of quality things came out of that. One thing about our hospital was that, and we still do, have quite a few people that have been here a very long time. And overcoming this is the way we've always done it, why should we change, is one of the big challenges that we faced. And I think the consulting team really helped us break down some walls. And specifically, we looked at our marketing strategy. We talked about really expanding that, focusing that on the right areas, getting some good direction and improving our approach to that. We talked about really working on policies related to finance. And, we had done a lot of things to comply with the 501R requirements, but we took that further with this team to look at an early out program, to look at changing our policies about private pay. In a town of 3,000 people, it's hard to be pretty firm on collection sometimes, but we have to be fair, we have to be consistent, and we really looked at policies and cleaned some things up. I mean, we had some very large accounts that people were paying $10 a month on. So we took a hard look at that. We've cleaned up a lot of those things. Many, we'd already started down the road of point of service collections, but those improved as well. We talked about probably more accountability at the department level, which I was very used to in previous areas, but in our hospital we had really left that budget accountability to the CFO, CEO, and we've moved that now to the departmental leader level, and they have much more accountability and management of adapting to change. If volume goes up, they have more leeway, I guess, as well as more responsibility. And we ended up looking at a 2-year strategic plan, which we have gone well into at this point, and just really continue to make good progress going forward. I don't want to take too much time, but I could go on. There are many, many more areas. One more thing I'll mention, Terry, is the fact that we discontinued a service that was really going nowhere, but in the board's opinion, it was an essential thing. It was our OB program, and we had dwindled to less than 80 deliveries a year. We had a single provider. We were struggling to meet quality measures, and the team really helped us take a look and say, look, if it's not viable, if it's not producing and not contributing, we need to really look at it. So since then, we have discontinued it, and there was not one utter in the public about a problem. We were able to make an agreement with a major university, and now we are implementing a telehealth program to access their very large OB department and their expertise for both our clinic and our emergency department folks. So didn't replace it, but we added value after we DC'd the other program.
And I think you mentioned the magic word there too, David, that it's about value now. You know, it's terrific to have all the services that are there, but as you're saying, a small rural hospital has a limited amount of resources and really needs to focus on the things that it can do well and can do of high value. In some cases, and I'd cite hospice, for example, sometimes it just is no other replacement in that regard, and you get into some difficult issues, in some of these areas as well. But having that conversation about value and about sustainability, et cetera, is really something that, rural hospitals across the country are going to need to be having. And again, we recently had a rural hospital financial summit meeting. Eric was one of the participants, but we had kind of the best consultants, hospital leaders in the country, and it was a small group in that regard. And when the number one recommendation that came out of there, because you guys have touched on some, get your physicians involved, prepare for population health, et cetera. But the number one recommendation is be as efficient as you possibly can under the current payment system, because you're going to have to do that first before you're going to make that a successful transition into the new dimension. So I kind of hear a little bit of that coming from your comments as well. Melissa, I'm going to ask you the same question. Tell me a bit about kind of what came out of the consultation process. Kind of did finances improve? Give me a few of the outcomes that came just for your hospital.
Certainly. Well, Eric's group and team really forced us to quantify a number of things, and then really, I think David said this as well, created a sense of urgency on a couple different projects that we had been dragging our feet on, namely our 340B program. We have the unique kind of position where our sister organization owns our retail pharmacy in the community, and we've been kind of just dabbling in the 340B program, and we really spent some time and focus on that, and we're able to get that up and running, and between the two facilities really had about $1 million uptick in our bottom line because of that program in this last fiscal year, which was huge for us. And then the other project that really came to the forefront, and it's something that we've been talking about, was a new clinic build for our main clinic here in Pender. And we purchased our clinic about 3 years ago and knew that ultimately was what we wanted to do. Eric's team really highlighted the need to really move that to the top of our list, and so we are in the process of doing that now and are in the design stage and really hope to have that building up and completed by next December. And so I think that timeline went from a 3-year or a 5-year program to and dropped it back to 3 years. So really sped that process up. And then the other one that I just wanted to mention was our swing bed program, and we really had been kind of straddling that as far as having, an average of 3 patients in our swing bed volume year in and year out, and really set the bar that we wanted to have a minimum of 5, and creating an action plan around that, and the staff really took that and was able to drive that program, and for several months in a row we averaged 7 to 8 patients in that program. So I think that energized the staff as well, and gave them a sense of empowerment. We were able to take take those numbers that we were able to put in front of them and really use it and capitalize on it.
Well, so one of the questions about the swing bed program is, will they be able to be regarded as in the new accountable care organization? And you are in one. That's why it's fascinating to talk to you about that. Is there, you know, it strikes me that, again, the bottom line here is going to be, can we provide value in a swing bed, even though, you know, it might be cheaper to send a patient to a nursing home, et cetera. Have you thought about that, and has it been an issue with your ACO or anything of that sort?
That has certainly been a discussion point, particularly with the ACO, and trying to tell our story and really teach them our cost-based reimbursement. And that is one hurdle that we've had to kind of overcome, that they don't understand how the calculations work. And so really telling them that as they pull out volume from our swing bed, that it actually makes those costs go up, and so it's kind of a self-fulfilling prophecy. But if we do the opposite and really kind of align our strategies, and if we're working together, those big hospitals can work with the critical access hospitals and drive some of their costs down by focusing on actually increasing their volumes overall, but then also creating some protocols on the backside of what are their expectations, and proving to them that if they've set some protocols for us that we can meet or even exceed some of their expectations, and really talking through, yes, sometimes those nursing homes can be cheaper. However, in the hospital setting, typically we have more RNs that are dedicated to those patients, and that we are also focused on readmissions. We understand readmissions, and our goal is also to prevent them. And that is sometimes a struggle that they have with some of those skilled nursing facilities. And so we can partner with them more closely, particularly since we're part of their ACO, and overcome some of those obstacles. But it is definitely something that we're continuing to have discussions about how to improve those lines of communication.
And one of the demonstration projects that I would point you to, if you haven't seen it already, is the Mayo Clinic's work, and I'm talking about the Mayo Clinic in Rochester, Minnesota. It's work with its dozen critical access hospitals in the three-state area surrounding it, Iowa, Minnesota, and Wisconsin. And they not only documented a huge benefit to their critical access hospitals, but they documented a very big financial advantage for the Mayo Clinic system itself. And I really think the key, and I think you pointed to it here, is that if you can do things with great quality and a care coordination standpoint, you're going to get folks out of that setting quicker, particularly for post-acute care. And secondly, that there will be higher quality, which they also documented. And then third, the chance of readmissions, which is extremely high in nursing homes, partially because they tend to be disconnected from the system, can be lower as well. So that's, I think it's an important consideration, but it is a big topic in a variety of different places across the country. Eric, I'm going to ask you a question now in terms of one of the things that you said. It took me a while to kind of understand the concept of. Eric has one diagram, so I really do recommend you go in either on our site or on the Stroudwater site. But you have that one slide which really projects the kind of the transitioning of the payment system and the things that need to be done by rural hospitals kind of along the way. You know, not a laundry list of things, but the key pieces. And one of the ones you have on there is rationalizing the system itself. Could you talk a little bit more about that concept and how maybe either of these hospitals would help to fit into that concept?
Sure, Terry. So what Terry's referring. Sorry, guys. I thought I was muted, and then I was not unmuted.
No, go ahead.
So what Terry's referring to is this I think it's a graphic called the transition framework, and it's to help hospitals think about how to essentially transition the delivery system, the sick care model that we're fundamentally about right now, create a health system, and transition payment, but keep them in lockstep with where the payment system is. The thinking here is that if we go all the way to sprinting around creating a health system and we're still fundamentally in fee-for-service, we take out volume and we close our hospitals. And so what we've got to do is think about, what are the things that we have to do to maximize fee-for-service, because that's what we're in today, but create a pivot to the new world. As the new world becomes more and more payments based on a population or accountable care population, we've got to start thinking about now kind of balancing our delivery system, our payment system, and our population health system, kind of in the middle, and create a further step out towards when the payment systems get 75% heavy into accountable care payment, and then we've got to go all in. Well, one of the key pieces of transforming our sick care model is we call it rationalizing the service area. That's big MBA speak. Essentially, it's coming together within different regions with the purpose of sometime out in the future, probably 5 or 6 or 7 years out, taking out big chunks of fixed costs. Because we have too much sick care right now. We have built, because we're paid for sick care, we got a lot of sick care, which means we built a lot of excess capacity. As we start to bring down the demand for sick care, we will have to right-size our fixed costs by reducing them. Most of the fixed costs, by the time the payment system gets out into that future, are going to be specialist technology and bricks and mortar, which hospitals, when we start to think of them as bricks and mortar, become cost centers. And frankly, a lot of those cost centers are in the big cities where they created this arms war to meet demand for a sick care model that we were being paid for. And so what this rationalizing the service area, which is, again, we should start thinking about a strategy for that now, is coming together, aligning within our regions with other providers that choose to have our same values and recognize kind of appropriate value for our rural hospitals, to start to align with them, that so sometime in the future we can look and start saying, are there opportunities to reduce our fixed costs, i.e. specialist technology and bricks and mortar. We don't want to be doing that today, because today those are our revenue centers. The second thing it does is it allows you to come together in regions of providers to aggregate patient lives, right? So we go from 2,000 lives attributed to a critical access hospital in Nebraska to aggregating in regions where we can pull together 100,000 or 150,000 covered lives, where then we could start to take on more insurance risk because we've been able to diversify that insurance risk. And the end goal of this thing is large provider-sponsored health plans that are led by the larger systems as they start to develop. And so, that third piece of transforming delivery system is, rationalizing the service area, coming together in regions, developing a strategy to do that. So sometime in the future, taking out big chunks of fixed costs as we decrease the demand for sick care is going to be pretty important.
Yeah, let me ask a question to David then, and then I'm going to follow up with one from Melissa. David, are you currently a part of a regional group or a network of any sort as an independent hospital? Kind of what are you seeing your options looking forward to working with other providers?
Well, we are part of the Greater Delta Alliance for Health, and that's 10 hospitals in southeast Arkansas. And we've made a lot of traction in the area of providing access for patients to education and as well as provider education, more in the nursing, clinical ancillary groups for certifications and things like that. And we have made a lot of progress in that area as a group. We haven't, as a group, delved into ACO type activities. So those things are out there, possible. There are some thought and some discussion about that. That alliance has primarily critical access hospitals, but 2 of the hospitals are PPS. So there's a little bit that diversity sometimes assists us and sometimes complicates things a touch. But it's a great group with a lot of success in its past. Where it could go in the future, again, is kind of untapped at this point. We are a long way away from Central Arkansas, which is where the primary larger medical centers are. We're on the very southeast corner, literally 20 miles from Louisiana, 6 miles from Mississippi, and there's no good easy way. There's a good way to get here, but it takes quite a while. So we're kind of off the radar, so to speak, but we're not unaware of the potential need for alignment and further partnerships down the road, especially Eric was talking about when the specific costs of specialists and the fixed things become more in need to be reduced and utilized.
Yeah, and you know, basically, I'll get back to our summit meeting that was held this spring, and you know, it's pretty clear for the folks that sat around that large table that rural folks are going to have to work together, either in networks, as you're saying, or they're going to have to be part of larger healthcare systems. There doesn't seem to be a whole lot of alternatives to that. But that doesn't necessarily mean that they have to either, let's say independent rural hospitals have to jump into ACOs or do anything immediately. The most important thing they can do is to improve their value and then collectively start working together to collectively provide value, et cetera. And there's time, there's really no reason to panic to jump into an ACO or something, particularly if you're not very well prepared. And it strikes me that both your hospitals have done the groundwork to begin that journey that, as Eric indicated, is going to probably take years to complete. But we're pretty confident that that either networks or being part of a healthcare system will be necessary, but that the single most important thing to do is to be as efficient and as value, to have your hospitals be aware of what is happening, to have your physicians aligned. You know, some of these preliminary steps don't require jumping into the early innovation and population health models. Melissa, I want to ask you, now you are a part of a accountable care organization, and that doesn't necessarily mean, I don't know much about your accountable care organization, but what I know is that a lot of rural hospitals are part of urban-based ACOs, and to some degree that's great. In other ways it presents some challenges. Could you talk a bit about your situation?
Right. So we kind of jumped into the ACO as part of a grant. Our big organization was able to obtain a CMMI grant that funded some health coaches in our critical access areas as well as the big urban centers. And so we wanted to take advantage of that. And as part of that grant, we also joined the ACO. And so initially, and I think when Eric came to our hospital and started asking us some questions, they're like, well, what have you changed? And we're like, well, we haven't changed a whole lot. So at that point, we were taking advantage, obviously, of the funds for the health coaches and putting some processes in place so that we could prepare for population health. But other than that, there was not a whole lot coming from the ACO. So at that point, we were able to start asking some pretty pointed questions and really kind of put the ACO maybe on their toes a little bit as far as being able to answer some of those questions about how does the critical access hospital or rural hospital play a part in the ACO and what's in it for them, and really understanding what our value is to the ACO, knowing that, you know, a large majority of our costs are primary care. And when we start talking about some of those things that Eric mentioned, the bricks and mortar or the huge cost of technology. Even at the hospital level, although we have some of the technology, it's not as expensive as what you're going to see in those urban settings. So when they start talking about cutting costs, those costs aren't coming really necessarily from the rural hospital. So how do we play a role in that accountable care organization? And so we are, as that grant is coming to a close, really questioning, are we with the right partner, and stepping back and saying, evaluating what else is out there. And so sometimes that makes things fairly uncomfortable, but feel like we do have a large value and we need to know what that value is, and the accountable care organization needs to create some value for us as well, otherwise it's not a good fit. And so we're in that process right now. We have about 1 year left of the grant, and so really focusing on what are we going to do at the end of the grant period.
Yeah, I think you said that very well. In essence, rural hospitals, if they are efficient, if they are good hospitals, don't have to come hat in hand here. They have tremendous value in the system. They don't have a ton of resources to prepare, et cetera. So it's nice to be able to have some outside support, obviously. Kind of one last question for you, Melissa. What sort of challenges have you had as you're moving to population health? And you know, how successful has that program been? Anything you'd want to share with us there?
So we're just in the beginning stages of preparing for that population health, and we actually created some organizational goals around that focus, and really focusing in on some of those preventative tests. Again, we're not quite in the situation where we're being reimbursed for that population health, so we still want to be taking advantage of that fee for service. And so we really focused this last year on preventative tests, and we actually saw a huge increase in the number of preventative tests that we were utilizing for our population. And so that is really taking advantage of those health coaches and making sure that we're scanning each patient's chart to make sure that they're taking advantage of any preventative tests that are available to them, especially if they're covered by their insurance programs. And so that actually increased some of our volumes, at least in the short term here, as we're preparing to take that step. Some of the hurdles that we're going to see, you know, trying to get our physicians aligned in that they're currently paid for volume as well, and so preparing them is going to be a big step in that process, and a hurdle that we haven't overcome yet. And so those are going to be some pretty long, lengthy discussion of changing their focus from purely volume to focusing on some of those quality measures, and then how their reimbursement changes as our reimbursement changes. And it may not be the same providers that are at the top of the fee-for-service that are the top under the value or quality, but maybe they are. It depends on how easily they're going to transition as well. And so trying to prep them early on for making those transitions as well.
David, do you have a perception of how your hospital may be moving to population health management?
You know, we've worked really hard in the areas of, just like Eric mentioned, the readmissions, the quality areas. We've achieved very high quality. We rate along with the top hospitals in the state in the area of quality. And what we do in the hospital, we have reached outside the hospital. We had a very successful campaign that involved several stakeholders, the city, the school system, some local people, some people very fortunately with expertise in larger city areas with population health. And one of the local girls has a degree in public health or doctorate in public health, so she's been instrumental. But put together that group and really started a healthy living campaign for our little town and reaching out to the entire county. And we've done a few workplace wellness things, just really awareness. And there's diabetic education going on that has been very successful in our area, and people just don't know what they don't know sometimes, and we've seen a lot of really great individual successes, and we're hoping to keep building on that.
Yeah, I think you both mentioned something that two extremely important activities here. One is the health coach side of it, and I heard Melissa say that with some of this funding, she's able to help support her health coaches, and health coaches are going to be essential. They'll be a part of that system delivery team of the future. We're absolutely certain of that. But David, you also talked about if you don't have the money to hire health coaches at this moment, one of the things every single hospital could do would be to form this community group that you talked about. That I just can't tell you how important that is, because down the road, when you and the hospitals might have full responsibility for the health outcomes of the population in your service area, and we think that's where things are going. It's going to be extremely important that you work with the long-term care providers, the mental health providers, the rest of that community, and let's not wait till 5 years down the road to have those conversations. We can have them right now, and we can have them, after work. We could have them, in our hospital with very little effort and virtually no money expended. What I can tell you is that these other elements of our healthcare service delivery are not as informed about this as we are in the hospital industry. They really need help, guidance. They're just as uncertain as, maybe even more so, about the future than our hospitals. So I really like the idea of working with the community. Eric, any last comments from you? I really, really appreciate you folks being a part of this conversation, and I think it really nicely capsulizes what we've been hearing from hospital leaders across the country on the successful side, particularly that we're making this transition. We know we need some help from the outside. We're getting some of that. We're working together. And Eric, any final comments?
Yeah. Just quickly here, is that both of these hospitals, David and Melissa, one of the pieces you heard indirectly from what they were saying was that in this transition framework, as we start to plan out the transition of our sick care model, one of the things that is here and now, right now, because our payment system has already moved, it's not just straight fee-for-service anymore, is this idea of becoming more efficient and focusing on patient safety and quality is the most important thing right now. And we've already, we've lost 75 rural hospitals now in the last 6 years that haven't figured that out. And one of the biggest opportunities I'm finding out there to become more efficient, and you heard it from both Melissa and David, was the fact that a lot of department managers think of themselves, using a baseball analogy, as catchers rather than pitchers. And they sit behind the door, they wait for volume to come in, and then if it's a wild pitch or something, or it doesn't come at all, they'll point at the pitcher and say, it's that person's fault. It's the doctor's fault. We did this or we didn't do that. One of the things that we've been able to see and get the greatest effect on improving efficiency is engaging the department managers as pitchers of their department, that they own their department, that they're accountable, that they want to get out and be part, and they feel, Melissa used the term, they feel empowered. And frankly, if you want to take 5% out of your cost structure, increase your volume by 5%. And that'll make you much. It's a lot easier to increase your volume by engaging and empowering your department managers. And frankly, that's probably one of between that and aligning with your primary care physicians are the two most critical pieces of the puzzle that we've got to pull together today. Thanks for having me on the call.
Yeah, I really appreciate it. I want to thank all of our speakers, Melissa, David, and Eric. I think this has been I always enjoy these calls, so I personally thank you as well as our organization in that regard. If you have questions for any of them or for us, please send them our way. We will answer them. If the question for Eric or any of our speakers, we'll get their response and get back to you as well. Thank you, everyone, for being on the call. And again, I encourage you to go